Can you all hear me? Good morning. Good morning. Good morning. Okay, now you guys are waking up. So thank you so much for being here. I am thankful that you have taken the time out of your busy weekend to attend our essential legislative conference. It is with great pride and heartfelt gratitude that I stand before you today to share a milestone in our journey to ensure that every individual living with sickle cell disease in Georgia receives the care, the support, and the hope they deserve. For over 50 years, the Sickle Cell Foundation of Georgia has been at the forefront of advocacy, education, and care for individuals and families affected by sickle cell disease. But as we all know, our mission extends far beyond the city of Atlanta. It reaches into every corner of this great state. That is why we have created powerful partnerships across Georgia to expand access to services, especially in underserved and rural areas where resources are limited, but the need is great. Today, I am proud to announce that we have established a statewide network of partnerships in Atlanta, Augusta, Columbus, Hinesville, Macon, and Savannah. Together with our trusted partners, Tapestry Connections, Dr. Dolores Mitchell, Sickle Cell Association of Savannah, Angela Shepard, MTS Sickle Cell Foundation, Inc., Mapilla Don, Lockhart Morgan Foundation, Inc., Gwen Morgan, Association of Sickle Cell Lower Chattahoochee Region, Lois Williams, and Beyond Sickle Cell Disease Foundation with Crystal Stone. We are bridging the gap in care and bringing hope to the heart of every community we serve. Through these partnerships, we share vital resources to help our warriors and their families access medical care, transportation, utilities and rental assistance, burial assistance, mental health counseling, food and clothing support, education and advocacy, hematology and holistic care, infusion and hydration support, nutrition and wellness planning. These are not just services, they are lifelines that strengthen families, restore dignity, and ensure that no warrior stands alone. To reach even further into Georgia's most remote and rural communities, we proudly take our 54-foot mobile health hub on wheels. This fully equipped mobile unit brings sickle cell testing, education, and essential services directly to the people. This innovative mobile hub allows us to deliver care beyond the walls of the clinic, bringing hope, screenings, and vital support right to the steps of those who need it most. We have also formed strong collaborations with federally qualified health centers throughout the state of Georgia. With their support, we can find a traveling hematologist, a nurse practitioner, and community health workers in each of our partner locations. These dedicated professionals are the heartbeat of our outreach, bridging clinical care and community compassion, walking alongside our warriors every step of the way. While we are proud to serve metropolitan area, we also recognize that underserved communities exist even within our largest cities. To meet those needs, we have formalized partnerships and MOUs with Curtis B. Cooper Primary Healthcare, Inc., Valley Healthcare Systems, Emory Carbondale Hospital, Grady Memorial Hospital, Lamar Medical Center, Morehouse School of Medicine, University of Alabama Birmingham, Diversity Health Center, Macon-Bibb County Board of Health, Atrium Health Navicent and the Medical Center, Tree of Life Healthcare, and most recently, the Richmond County School District, and we are not stopping there. We're currently developing new partnerships with Phoebe Putney Memorial Hospital and Southern Regional Medical Center, expanding our reach even further across the state. Training and education in partnership with Morehouse School of Medicine, we proudly offer a 4-hour CME accredited training on evidence-based protocols for the management and treatment of sickle cell disease. This course equips non-specialty providers with the knowledge and confidence to deliver high quality, compassionate care, regardless of their location. That's a lot, right? Well, I got tired of it, Our mission, hope in every heartbeat. Our mission remains simple yet powerful. We want every warrior in care, and we want every warrior to receive the best possible services so they can live well with sickle cell. Together, we are building a future where no one is left behind, where access, equity, and hope are not privileges, but promises kept. I would like to extend my gratitude to our board of directors for their everlasting support, sponsors, warriors, caregivers, and dedicated legislators for their ongoing support. I also want to thank my staff. Without you, none of this would be possible. But because at the Sickle Cell Foundation of Georgia, we believe there is hope in every heartbeat. Thank you guys so much.
Thank you, Tabitha, for that very warm welcome. Welcome to the first panel of the Sickle Cell Foundation of Georgia Legislative Review and Policy Impact Conference. We'd like to welcome our panelists. Dr. Beatrice G. is a pediatric hematologist and oncologist with Children's Healthcare of Atlanta. She's also an associate professor in the Department of Pediatrics at Emory University School of Medicine and a researcher who is focused on sickle cell disease. Elizabeth Hassett, an attorney, is a consultant at Levitt Partners in Washington, D.C. She provides federal policy analysis and strategy to clients and manages multi-sector alliances. One such alliance is the Sickle Cell Disease Partnership, which is comprised of more than 15 healthcare and sickle cell disease organizations, working together to advance federal policies that support individuals with sickle cell. Aaron Crump is the head of U.S. Government Affairs and Policies for Agios Pharmaceuticals. He was previously the Senior Director of Global Policy and Public Affairs for Pfizer. LaToya Thomas is the U.S. Head of Public Policy and Government Affairs for Terumo Blood Cell Technologies, a global medical device company whose products enable healthcare providers and biotech innovators nationwide to collect and prepare blood and cells which help treat challenging diseases and conditions, including sickle cell disease. Welcome, panelists. Thank you so much for coming and starting off this panel with us. So the first question we have is for Dr. G. Hi, Dr. G.
Good morning.
We're seeing a system-wide federal reorganization of this country's leading disease and healthcare research institutions. What impact is this having on federal funding for sickle cell research?
I think the simple answer is that it's very challenged right now, but I wanted to talk to you today as a representative of Emory University and Children's Healthcare of Atlanta and the American Society of Hematology, where I'm members of several committees, including the Committee on Practice. We've been actively advocating for both sickle cell research and services at the Hill, so really there for the cause. So the National Institutes of Health, as you know, is a major source of research funding for much of sickle cell disease, including the groundbreaking new gene therapy treatments, as well as the newer FDA-approved medications. So a lot of things have been funded by early research by NIH. They've also funded implementation consortium projects, which is groups of clinicians and practitioners to study evidence-based approaches to treatment. So the current federal administration recommends 40% reduction to all of NIH across the board, which can include the centers that support us, including heart, lung, and blood, and diabetes and kidney diseases. The National Center for Complementary and Integrative Health, which supports trials that study non-pharmacologic therapies such as acupuncture, meditation, movement, and what we call the natural remedies, is slated to be completely closed down, so that further research on these non-traditional medicine approaches is going to be cut off completely, and that's going to be a topic of tomorrow's discussion on alternative therapies. So it's going to be a rough haul. You probably also heard that at CDC, a very important unit called the Blood Disorders and Public Health Genomics Division has been pretty much administratively closed. But thankfully, due to a lot of advocacy among many of us in this room and the American Society of Hematology, the Sickle Cell Data Collection Project, or SCDC, continues to be funded, and Dr. Snyder here in the front will be talking about that a little bit later this morning. Luckily, within Health Resources and Services Administration, HRSA, there's flat funding for the sickle cell treatment demonstration projects and the newborn screening programs, but that does not really help the research situation very much. So historically, funding of sickle cell research is at a much lower level than comparable genetic disorders affecting other groups of people, such as cystic fibrosis. So on the heel of the recent gene therapy breakthroughs, the current reductions will definitely slow the progress to better treatments. It has already kind of cut off the pipeline of young underrepresented scientists to do sickle cell research, and we all need to continue to advocate that the budgets to NIH and CDC be restored, as well as funding to unfairly terminated sickle cell research.
Wow, that's eye-opening information. Elizabeth, good morning.
Morning.
Tell us more about the Centers for Medicare and Medicaid Innovation Cell and Gene Therapy Access Model, and how it may be impacting our sickle cell warriors. What is the status of the sickle cell disease gene therapy enablement in Georgia?
Yes, thank you for having me here. So just to start broadly with what cell and gene therapies are for folks a little bit less familiar, they replace or modify malfunctioning cells in the body. So cell therapy, bone marrow transplants, those replace sickle cells with donor cells, which can have some complications associated with treating the donor cell and the patient's cells. But our focus here is gene therapies, which is Dr. G was saying, were the 2 new treatments approved by FDA in December of 2023, so almost 2 years now, with Casgevy from Vertex Pharmaceuticals and Lyfgenia, formerly Bluebird Bio, now rebranded to Gentex Biotherapeutics. So these therapies use the patient's own cells to produce healthier red blood cells without a donor. And they are transformative treatments, but for some people, and we may hear in the media that they are quote unquote cured. That's not necessarily always the case, as folks can have persisting health challenges even after receiving the therapies, based on what their pre-existing state of the disease was before the therapies. But to discuss some of the challenges with coverage and access, it goes without saying that they are extremely expensive without sufficient insurance coverage, in the $2 to $3 million range, not including other medical care associated with the procedures. There's also some risks of infertility due to the chemotherapy that has to be administered to prep the body for receiving the new cells. And not everyone qualifies at baseline, and there's different insurance requirements and eligibility requirements. It's also a huge time commitment from start to finish, about 8 to 12 months. So that can really impact what you can put on the side of your life. So those are some of the challenges of coverage and access, but this has really led to some creative thinking and innovative policy solutions, including the CMS Innovation Center's cell and gene therapy access model. The first focus of the model is sickle cell disease. And unlike some of the challenges that Dr. G was discussing, the Trump administration has actually been highly supportive of the model. 35 states have voluntarily agreed to participate in the model, and they're currently undergoing implementation efforts. But CMS directly negotiates with the manufacturers outcomes-based agreements, and these tie payments for the therapies to the patient health outcomes produced from them. The idea that having a single negotiating entity can help to alleviate some of the cost burden. However, in Georgia is not participating in this model. They're taking a different approach. About a year ago, the Georgia Drug Utilization Review Board announced that it would be covering Casgevy and not Lyfgenia. And it appears that Georgia's kind of trying to create its own state framework for covering cell and gene therapies without having to rely on the federal government moving forward as more and more therapies get developed. So there's pros and cons associated with that, as you can imagine, but kind of the state of cell and gene therapy right now.
Wow. How many of you guys knew that information out there? I did not think Trump supported anything, so that's good to know that there is some type of hope going on there. Thank you. The next question is for both Dr. G and Aaron. Hi, Aaron.
Good morning.
Good morning. Let's talk about the Sickle Cell Disease Comprehensive Care Act. Why is the bill important, and how can it help sickle cell warriors?
Great. Well, it's a pleasure being here. And before I delve into the nitty-gritty, I want to thank Algen and the team. I know how much work it is to pull off these conferences, and it's a fabulous venue. And so thank you for the hard work. I really appreciate it. So yeah, this bill is something that has been introduced a few years ago. And I should preface my comments by, I found it very heartwarming. I've been in sickle cell in various companies over the past 4, 5, 6 years. And what's so unique about sickle cell is we've been working as a community, as an industry on this bill, right? This is not something where certain companies are doing certain things. We as a whole, right, are working towards betterment of sickle cell patients. And so that's a really unique thing when it comes to sickle cell. And one example is this bill at the federal level. And again, it's been an ongoing effort for several years. Things have been slowly in DC, as we know. It's a long road to get it bill passed. We're continuing to work on it. Essentially, what this bill would do would allow states to create medical homes specifically for sickle cell, right? So historically and typically, when CMS has allowed this, is for tool-borne chronic conditions. This bill will allow states just for sickle cell to create medical homes at the state level. And we all know the importance of having comprehensive care when it comes to sickle cell, right? And so medical homes essentially allow the provider to provide that coordinated care, right, like from soup to nuts for these patients, which is critical, right? We know these patients have a lot of needs. There are a lot of different areas that need to be addressed, and so medical homes are a type of system that allows that comprehensive care and coordination for these patients. So that is, in a nutshell, what the legislation would allow states to do. It's been introduced in the House and in the Senate. This has been the case for several years. We've had some really strong champions, Senator Scott and others over the years, but we have to continue to build that momentum and support for the legislation, because in this environment, and frankly, in any conference, it is very challenging to get anything through the cross line. We're optimistic, but we need to continue to build support from the House Republicans, Senate Republicans, Democrats in the House, Democrats in the Senate. We need to make this as bipartisan as possible and as much support as possible to get this to the finish line. But I think this is an example of we can really truly make a difference, right, at the state level, where we know a lot of Medicaid patients are, that allows states to provide this type of care. And I would just also mention that part of what this legislation would allow is the government to basically provide some, kick in some funding for this, right? So that is what the legislation would do in a nutshell. We're continuing to push for it. Knock on, well, this isn't wood, but knock on wood if we can, that we'll get through the finish line this year. But if not, we're going to continue to work on it as an industry, as a coalition. We're going to make this happen. I know it might be this year, it might not be this year, but we'll make it happen eventually. So that's what it is in a nutshell.
And from a patient care point of view, the important features include behavioral and mental health care. So not just seeing a physician or an advanced provider, patient and family support, community and social support. So I think that the Sickle Cell Foundation of Georgia has built a great framework across the state, working with primary care providers and specialists to kind of have the infrastructure to actually do this. Coordinated care will allow more preventive services and treatments, and all of that reduces life-threatening complications, will improve quality of life and the productivity of people living with sickle cell disease. And without all of this, the whole purpose of the Gene and Cell Therapy Act is kind of a moot point if people aren't healthy enough to get cell or gene therapy. So I think it's a good direction, and we hope that the federal government does continue to support it.
Thank you. Thank you for those comments. LaToya, good morning. The Accelerating Kids Access to Care Act will require states to establish a process by which qualifying out-of-state providers may temporarily treat children under Medicaid, the Children's Health Insurance Program, without undergoing additional screening requirements. What is the status of this legislation and why is it important?
Well, I feel like Aaron queued it up when he mentioned that things are moving slowly in Congress right now. The Accelerating Kids Access to Care Act, on the Senate side known as S752, on the House side known as HR 1509, had a very brief moment in the sun in December of last year. I think you can all remember that when we thought we were going to have a bipartisan reconciliation bill at the end of the year, and that was blown up in a phenomenal fashion. This bill, we shouldn't be talking about it as a bill, pending bill in Congress. We should be talking about it as an enacted act, but we missed the opportunity to do so. The bill would streamline the ability for healthcare providers, particularly specialists, to become enrolled in Medicaid and to treat children who are covered by Medicaid. I think we oftentimes talk about services and treatments themselves just not being accessible, but sometimes the root of the problem is just not having enough specialist providers in the community so that a patient can see them. In this case, it would deal with that administrative burden and make sure that patients, particularly children and their families, can get access to the right care at the right time when they need them. I think we know there's not a cell and gene therapy site in every state. There are many patients in southern Georgia who go to Florida. There are folks in Alabama who come to Georgia. There are folks in South Carolina who come to Georgia and vice versa. There's a rich hotbed of medical innovation in this state. But leaving healthcare providers in a position to not get paid for it if they're treating someone in a different state, especially when they're covered by Medicaid, I think is a big, phenomenal administrative burden that can be alleviated with this bill. The status of it is that it's got 38 co-sponsors on the Senate side right now on a bipartisan basis. It's got roughly 88, I think, last time I checked, on the House side on a bipartisan basis. So we're essentially in the same position that we were in the last congressional session, hoping that we can get a markup as it's been marked up in the respective committees that it's been referred to. I think that unfortunately, we're not quite sure the status of the bill this year. One big beautiful bill, Medicaid reform, that was included in that, took up a lot of space when it came to Medicaid reform, talking about that particular program. There's not a lot of appetite on both sides to try to figure out what the next steps are for Medicaid. I say that now, but tomorrow, who knows what the headlines might be, right? So we continue to monitor, we continue to have conversations. I encourage you all to continue to have this conversation with lawmakers in DC. I will note that because this particular bill is just focused on children covered under Medicaid, it it doesn't deal with that transitional care gap that we're all familiar with. It'd be nice to have a bill introduced that would address adults covered by Medicaid, ensuring that they have access to similar specialists as well.
Thank you, Latoya. So as we wrap up here, I want to think about the future. Can each of you share your thoughts on the best way to move forward with the sickle cell prioritized to keep stakeholders engaged in the current environment? For example, as you spoke about the One Big Beautiful Bill.
Okay, so as we're thinking about One Big Beautiful Bill, which we call OB3, that's what I'm calling it. I think did they officially rename it too? I think they may have.
I think it's just representation before.
OB3.
It's like a Star Wars character. Oh, is it OB3 Star Wars character?
Maybe. It is one area that's going to require broad stakeholder engagement, especially on the community engagement requirements, which is also an interesting environment here in Georgia with the pre-existing work requirements, which Georgia has extended until I believe the end of 2026. So this is an important conversation kind of at the national level, and also as Georgia is figuring out what they're going to do with their end work requirements. So OB3 requires for folks on Medicaid 80 hours per month of work, community service, job training, education, or a combination of those, and there's restricted verification requirements for the states. But we know that sickle cell disease is very unpredictable with recurrent pain crises, severe health impacts that can have folks on and off of work consistently. And so the partnership, Sickle Cell Disease Partnership, representing sent a letter to Centers for Medicare and Medicaid Services asking for some flexibilities in their implementation of OB3. We pointed, I won't go through the data points, but we pointed to a bunch of different data points and surveys and reports that did show, missed days of work, and as employment status decreases, the severity of disease increases. So we kind of set it up with all that data, and it really showed that community engagement requirements directly butt up against kind of the clinical realities of sickle cell disease. So with that, the partnership asked CMS that as it implements OB3 to leverage its regulatory authorities to exempt sickle cell disease under its, the administration will have to define some terms in the statute like medically frail, complex medical condition, a few others in which we could argue that sickle cell disease would directly fall under those terms. If CMS decides not to do a categorical exemption, the partnership asks for it to at least provide some practical implementation guidance to states, highlighting some of the flexibilities that states have to protect individuals with sickle cell, so specifics on how to deem an individual to have met an exclusion, kind of like looking at disease criteria, diagnostic codes, clinical markers. There's also, we can highlight not verifying more than once during the standard redetermination process, and there's some flexibilities with state optional hardship roles where folks, if they have an inpatient hospitalization throughout that month, they could be exempted in that month. So those are some of the strategies that the partnership is using to try to get some protections for individuals with sickle cell. We're going to be continuing those conversations at the federal level.
Well, so this is more, I would just say, and I alluded to this before, but it is really, really important for all of us to work together, right? I mean, there are a lot of course, issues, hurdles, borders faced when it comes to accessing care, right? And at Agios, of course, we're very hopeful that we will bring a new therapy to the market soon. Again, knock on wood. But whether it's our therapy or any other therapy, we are all for all therapies coming to market, right? it's not about one therapy versus another. We need all the tools in the toolbox available. And as you all know, there are very, very few therapies currently on the market, right? So it's not just about the therapies though, it's about access to care, right? We all need to work together, whether it's at the federal level or at the state level. I know sometimes it can get a little messy because there might be competing interests sometimes. But when it comes to this community and the needs, right, it's really, really important to work together. And I know sometimes there is, and I haven't actually found in sickle cell and other disease states between industry and the community, there's sometimes a reluctance to work together. From my perspective, there is absolutely nothing wrong with working together. We are trying to do the right thing by patients, and the only way we can do it is together. So that is my advice: work together, and when there are opportunities, take advantage of it and push it forward.
The only thing that I would add, in addition to the collaboration and working together, is that when the opportunity presents itself to comment, to voice your perspective, there have been numerous opportunities through this current administration, through both chambers in Congress, when they ask for your opinion on something, this certainly isn't the time to sit silently. And if they're asking for your perspective, it's intentional, largely because they want to learn. We know sickle cell really well, but as we know, every member in the House right now is planning for their jobs. They're all up for re-election next year, in addition to many members of the Senate as well, which means that there may be a new crop of folks in Congress for us to educate and inform, new champions for us to designate so they can come with us and collaborate with us, as Aaron mentioned. So when the opportunity does present itself, please chime in, because it certainly isn't the time to
I'd like to give us some hope in that there are successes in advocacy. With the SCDC, for instance, large letter writing and emailing campaigns were undertaken to help support that program, even though the parent organization at CDC is still closed. I personally have a grant for middle and high school students to have STEM mentoring with college students, children with sickle cell disease, to have specific mentoring from college and medical students. And we almost lost our funding because of our designation as being for minority populations. We also did a lot of strong letter writing and emailing and phone calling campaigns, and we were able to save our program and many other in the award system called the SEPA grants, which are NIH Science and Education Partnership Awards. So there is power in each of our voices. It's easy to get worn out though, you can only do so much at a time. But I think if each person takes a piece of it and advocates for the cause, we can emerge from this without losing out.
Thank you. Do we have time for questions? Okay, now I would like to open the floor to our beautiful audience in front of us. Does anybody have a question for any one of our panelists on any topic or any question that they have answered?
You can't ask about the shutdown, though.
No, it has to be this kind of really specific. No? Yes, in the back? We have a microphone coming to you.
So, good morning, Dr. G. I wanted to ask you specifically, I know you said that, SCDC was safe. However, what does that mean? I know they were safe, and I know they kept their funding, but also staff is cut. And so how are we gonna integrate the fact that staff has been cut, the funding is still there? How are we gonna get the job done with fewer people, even though, they were able to save SCDC?
We will let Dr. Snyder answer that one.
Well, for right now, CDC has assigned new project officers to us. But they have kind of said, it's a cooperative agreement for many of you guys that don't know. It's different from like a research grant where you just give all the money to the researchers and let them do their research. It's a cooperative agreement, meaning we do work in partnership and cooperation. So the CDC has basically given us folks that really don't know anything about sickle cell. They're scientists and they know about whatever they knew about, but they don't know about sickle cell. So the part of the cooperative agreement that was CDC's responsibility is, that's not gonna happen. So, there are, I'll talk about this a little bit more, I'll give you guys more context, but there's about 16 states that have this grant. We've all gotten our awards, so we all have it for the next year, and we are kind of self-organizing this year. Now, the plans, you guys might know more, the plans that I knew about were for this program to move to the new agency that's being created, the Agency for Healthy America. And that's the right, exactly. So that is the ultimate plan of this administration. How that's going to work, because it would be the next funding cycle, which would start in September. Yeah, next year at this time. This grant is supposed to move to that new organization, and then I'm not sure how it would be managed, but it's supposedly coming out of CDC and going to this new organization. But this year we're trying to work together to get it to do as much as we can.
I think
Thank you.
the experts who have been involved in these projects are self-organizing. I think we are seeing that in the area of vaccine advocacy as well. Even though the federal programs are shutting down.
Okay, question in the back?
Hi, so I'm a psychologist, a little transparency. And so like when mental health related bills or things are being considered on Capitol Hill, generally there'll be like an email push, like send this to your senator, call your senator, et cetera, et cetera. Yet I don't know, and I think it's just my ignorance, if that is being done for sickle cell disease. Like are there, send this to your senator campaign, call, and if it is so, how do we then get those who are advocates, those who work with stakeholders to participate in those? Because again, I know they are highly effective, but I've never encountered them.
Yeah, I think it depends on the bill, right? So the Comprehensive Care Act is going to take a lot of attempts and grassroots effort, right? Whether through ASH, the partnership that we're part of, because to your point, it's definitely very helpful and it's an important tool, right? When there's a piece of legislation introduced or something that we're trying to get pursued to the end. For members to hear from their constituents, I'm not involved in that sort of day-to-day, innocuous. A lot of the community has been trying to gin up support for it. And there's probably more that we can do to ensure that as many people like yourself are getting notifications with our efforts to push something through, the finish line. But that isn't, that is a very common, I would say, strategy, right? The organizations usually tend to do is to reach out to their members or constituents. It's a little bit trickier, right? If typically those communications go through, like if you're a member of a particular organization, right? And they will get pushed out to these notifications. But for someone that just wants to get involved, it's probably more challenging, right, to receive those type of things, and it might not be necessarily applicable to you. For example, if ASH sends out something to their members, it's going to be for the members, right? But there's, we can talk offline. I think I always like to hear what any just individual or advocate is wanting to engage, right? So we can get involved in that.
So I can comment as well. So in each state, like here in Georgia, we have sickle cell day in the capital, and we do arm all of our warriors and caregivers, anyone that is impacted by sickle cell, with the information to go to their representatives and talk about whatever bill it is that we're trying to get passed. And I know they do that inside of DC. So most organizations have sickle cell day in the capital all over the United States. And so we're always online, we're always promoting that. And so that's how we're getting information to our representatives about sickle cell. And so what state are you in? You're in Georgia?
So, I'm here.
Okay.
As my interest is something on the capital this year, but also just, again, when the bill is coming down, it's really easy for me to sit at my computer here.
Right.
And fill it out and send it, like say, I work with, transition age young people with sickle cell disease, to personalize it and just send it out or call. But again, I've never received anything or know how to do that. And in this kind of social justice climate, how do we engage all who are, advocates or allies to do the work or to contact someone or to talk about it, when they're with their friends, et cetera, when, again, I guess I'm looking for, and maybe this is not currently out there, and maybe again.
No, it is. We actually had all of the representatives online and 6 cells in DC, they organized it. So we had all the representatives from DC that was online and we were able to present to them. So each one was there, took down the messages that we were delivering. And so we're still waiting for a follow-up, but that did take place as well. And so we can speak more about that too, like I said, online. I think one opportunity of this group is that we could take the roster of people who are attending and have a mailing list, and then perhaps at the end of this meeting, come up with different times of the year where there will be specific campaigns about specific bills. Because I think the individual in the community is kind of lost as to who do I write to about what and when to have the most impact.
Melissa Bishop Murphy, I'm an advisor. I am also a Pfizer's Government Relations Director. And to add on to all that, the questions around about how to advocate, what I would say is advocate early and often, right? So up to Tabitha's point, they have already this information, but I would suggest to all of you that not only advocate to those Congress people and legislators who serve on the committee, but also advocate with your own legislator, so your own representative. So make sure that they know who you are. So during this time, during the legislative session, make sure you have a coffee, once a quarter with your state representative, your state senator. And then also go and visit your U.S. Congressman's office. They have an office in district, so you don't have to go to D.C. Make sure that they know who you are, because frankly, you vote for them. And so they're very responsive to people who can cast the ballot to make sure that they get back into office. So I will urge all of you to put on rotation some type of communications with your own state legislators and your U.S. Congressman and your U.S. Senator. Even if you're not talking to the U.S. Senator, which you probably want, or the U.S. Congressman, they have a health policy person in their regional state offices that you can speak to, and they need to be able to say, oh, there's an issue around sickle cell. Oh, let me call such and such, because they're my constituent, and they'll talk to me about that. They need to know you to that granular level, and if you're doing that, I would suggest to you will have more success.
Thank you, Melissa. Okay, I think that should be the last question for this session. We want to thank all of our panelists who have come from near and far to give out some very important information and share that with us. So thank you for giving them a warm round of applause. And if you want to do a little bit more, go ahead. Thank you guys so much. Okay, I learned a lot of that last panel, and there is so much more to come. So now I will be presenting the 340B drug. I'm just kidding. The 340B drug pricing program was created by Congress in 1992 to give a safety net to providers access to discontinued outpatient drugs for vulnerable patients. Under the program, drug makers must provide medicine at significantly reduced cost to eligible hospitals, clinics, with the goal of stretching scarce federal resources to reach more patients. But according to the Health Resources and Service Administration, or HRSA, the 340B program does not legally require hospitals to pass savings directly to patients, allowing many to change full price despite discounted acquisition costs. That's become a big problem. With us now to talk more about this misuse and why it matters is Melissa Bishop Murphy. She is the Senior Director of the National Government Relations and Multicultural Affairs for Pfizer Incorporated, with more than 30 years of lobbying and alliance development experience on the state and federal levels. Melissa currently lobbies in Georgia, South Carolina, North Carolina, and Puerto Rico. Additionally, works to build multicultural coalitions to advocate for greater success to healthcare and pharmaceuticals nationally. Melissa has received numerous honors and awards for her work, including the 2025 National Black Nurses Corporate Citizenship Award, the 2022 National Hispanic Caucus State of Legislators BPA Award, and the 2022 Healthcare Businesswomen's Association Rising Star Award. Welcome, Melissa, and thank you so much for sharing your expertise with us today.
Well, good morning. I'm going to need help, yes. So, thank you to the Sickle Cell Foundation of Georgia, to Tabitha, and to the wonderful planning committee that organized this legislative conference. I will tell you that the time is now to engage this. I've been around over 30 years in healthcare. I'm a healthcare attorney by training. And I will tell you that I was talking with Andy Ford, you're a really wonderful lobbyist. And Michael earlier before we got started, and we were talking about how bad the situation, the environment is, but we have overcome. We've been through all of this before. So the way that we overcame was through advocacy. So this is really, you guys really take advantage of this opportunity that the Sickle Cell Foundation has given you today and tomorrow to get educated, because it's going to take grassroots advocacy to just maintain where you are, to just maintain this really critical legislative session, whether it be on the state or federal level. I'm going to focus on the 340B program this morning. The 340B program is a federal program, but has really large state implications. The 340B program is the second largest drug program in the country behind Medicare Part B. A lot of people don't realize how big the 340B program is in terms of the cost. But it's the second largest one. So the 340B program is very complicated, and 15 minutes would not do it justice. But I will tell you, I have a video for you that I think does set the stage for those of you so you can understand what the 340B program is. So if you'll cue the video.
Many vulnerable patients rely on safety net programs to afford their medications. The 340B drug pricing program is a prime example. The federal program requires drug manufacturers to sell outpatient drugs at discounted prices to healthcare facilities that care for many uninsured and low-income patients. However, over time, the 340B program has evolved into a mechanism for some 340B facilities to boost profits while patients struggle. Meet Kate. Kate was recently diagnosed with Crohn's disease and lost her job, so she doesn't have health insurance. During her hospital visit, Kate's doctor prescribed medicine to help treat her symptoms. But Kate doesn't know that her hospital is a 340B facility, which purchased her medicine at a discount. When Kate arrives at the pharmacy to pick up her prescription, that discount is not passed on to her. Kate is told that her medicine will cost almost as much as she pays in rent. With this new monthly cost, Kate is forced to ration her medicine, as she cannot afford to take it as often as she is supposed to. Sometimes she skips buying groceries in order to afford her prescription. Since Kate can't always take her medication, her health is getting worse. If Kate's hospital and pharmacy participate in 340B and she is a vulnerable patient, why is her treatment cost so high? Those participating in 340B are not required to share savings from discounted medicines to directly help patients like Kate access their medicines. Through contracts with the pharmacy, Kate's hospital is able to charge her the same amount as a fully insured or cash-paying patient and pocket the difference. And we don't know if they are using the funds to help Kate or other patients in need. Through that contract, Kate's pharmacy gets to profit off the purchase as well, and so can the industry middlemen that negotiate drug rebates with the pharmacy. While well-intentioned, the 340B program is broken, and patients are still paying high prices. Some healthcare facilities honor the goal of the 340B program and provide vulnerable patients their medication at low or no cost. But many 340B facilities are not using the funds as the program originally intended. Large chain pharmacies and pharmacy benefit managers are raking in profits while patient health suffers. Will Congress take notice?
Hey, pretty grim, right? So, we know that Congress is not taking action. And so what has happened in the last few years is that there is state level engagements. So in fact, in Georgia, there's a bill, House Bill 139, make a note of that is supposed to fix this problem, but actually exacerbates this problem. One of the real issues around 340B is transparency. Where are those dollars going? Why is it going to the patient? So what there's a patient coalition that's working on this issue in Georgia. Their demand is that they want to understand where the dollars are going. Before this program is expanded, including more contract pharmacies, the patients are saying, tell me where the dollars are going. Why are the dollars going into my communities? We're seeing more community-based hospitals close, so they obviously aren't getting the dollars. I'm sure you're feeling it in your wallet because you're paying more for your medications. But here again, this is the second largest drug program in the country. But no one seems to, the patient doesn't seem to be benefiting from it directly. So what is the ask for you all today? The first ask is to join the patient coalition, and I have provide that information to you all. It's called RX Reach. It's led by Dorothy Leon Glasser, and she was at the sickle cell Hill Day earlier this year. The second ask from all of you, once you join the coalition, is to engage. There is information that's sent out almost monthly about what's going on. We understand that this bill will come up in January, so it'll come up fairly quickly. The bill in its current state does not address transparency and doesn't ensure that the dollars flow to the patient, and that's what we want to see. So the third ask is to advocate and make sure you're asking, how are patients going to get these 340B savings? So those are the three asks of you. I'm gonna stop here because I'm sure you have many questions and we want to be respectful of the time. All right, any questions? Yes, ma'am.
Something that patients can ask for, so if they are,
You can ask if you're a 340 patient. That's the first step.
I'm sorry,
You can ask whether or not you are the hospital or the pharmacy. Are you a 340B patient? Well, most people don't even know they're a 340B patient, so that's the first thing.
so would they also have to check to see if the hospital is a 340 hospital?
We already know the hospitals are 340B, so who are we? I guess I'm not.
Well, I guess what I'm trying.
Because we want to make sure the patient gets the discount, so the patient needs to ask, are they a 340B patient? And you can ask that, at the point of service.
Well, and that's what I'm getting to.
Okay.
I'm getting to whether or not if people are informed.
They're not informed.
Right, but in the interim, I know we're trying to get this legislation passed, but in the interim, can the power be given to the patient to ask for those discounts? Is that feasible?
Not under the way that, it's a federal piece of legislation, and because the federal government has not deemed to act on it, the states have been, introducing legislation. So there hasn't been, in Georgia, the legislation does not provide for the patient, asking for that discount currently, but it can be amended, right? So, yeah. Yes, ma'am.
Okay, I was wondering, there are other states that have similar legislation that provide for transparency and we model this bill after.
Yes, only one state has passed the transparency legislation thus far, and it was very limited. But yes, I can provide the states that have, that's the state that has passed the transparency. I think it may have been Indiana or Kentucky, but I'll get that for you. But we do have a model transparency legislation that we can share with you. Yes, ma'am.
Okay, if a patient's hospitalized, they are 340B patients, before they are discharged, who can they ask to see if they are considered a 340B patient? So therefore, they would know to continue to come to the hospital to that, to get their medication. Let me just preface it. Okay, I was case manager, okay, in our trauma one hospital. Yes, we dealt with a lot of undocumented, unfunded patients, low income, so forth. Our role upon discharge was to inform them of what resources were available to them. They were also able to get all their medication, every patient was able to get their medication upon discharge from the hospital. The ones that were unfunded or low income, whatever, we always told them to come back to the pharmacy, the outpatient pharmacy, to get their medication. But we never told them, or I didn't even know anything about the 340B. So my question would be, who would tell that patient upon discharge that you are a 340B patient? And therefore, it would be better for you to come back to the hospital outpatient pharmacy to get your meds instead of going to a CVS, Walgreens, etc.
So I was gonna say it should be the case manager, but you just told me the case managers don't even know. So that here again, that's education and transparency, right? So we need to make sure in the legislation that there's some requirement that the case managers also know whether or not the patient is a 340B patient. So thank you for that insight.
And let me just add to that, to what you just said. Now, CMS, everybody requires what social determinants of health questions to be asked them. I see where that could be a question incorporated in that to ask upon upon discharge, due to the fact that you're required to do an initial assessment of that patient's needs upon discharge.
Right.
And now that they're requiring the social determinant.
I don't know if that's still happening now since January, just so you know. But I agree with you that that should be a question that's asked by the case manager so that, because that's the work we all do, you know, trying to ensure that the patient once discharged still have access to the medications that you stabilize the patient on, and hopefully the patient will get even better. So I would suggest to you that it's not just going to the hospital outpatient pharmacy, because there are contract pharmacies in the community. So it should be that that patient has to just come back to the hospital. The hospital contracts with these contract pharmacies, whether it be CVS, Walgreens, or others. And so that savings should also happen at the CVS, at the Walgreens, and it's not. One more question? All right, I'll be here during break if you have additional questions. So thank you so much for your time and attention.
Thank you, Melissa. Now we are going to have a wellness break. I think we need to process all of this information that we have been given. So we will be back shortly.
The Sickle Cell Legislative Conference and Policy Review will return in 15 minutes. Please use your passports and visit the different stations.
Good morning, everyone. Yes, participants, I want to explain a game and activity. If everybody during your wellness break can get your bag, pull your passport out. So as you continue to hear presentations and have dialogue about policies and procedures, I want to make sure that you guys connect these opportunities to real life. So all of the activities that you see behind you, we deem policy in motion, a way to get active with intention. So your passport, the first page in your passport is blank, the inside cover. That's where your Polaroid picture is gonna go. If you have not taken your headshot, our photo booth is right here. We will take a classic Polaroid headshot of you. After you shake your Polaroid and your image becomes clear, tape it on the inside cover of your passport. The very next page you see is a list of the sickle cell genotypes. They are in order from most severe to moderate. Next to each one is a description, so you can learn about the genotypes. And to your far right is a health currency. There should be a numerical number. Now, inside your travel bag, you should find cash. Not real cash. Little stickers, currency. The amount of cash that you have should correspond to a genotype. So as of today and tomorrow, this is the genotype that you now have. Learn about it, understand it. The currency starts with the least amount to the greatest amount, meaning the most severe type of sickle cell disease would link you with the least amount of energy, aka cash. Now, on the back side of this black wall, there's a panel. There are 8 sheets of paper. Each sheet of paper represents a segment: wellness, daily life, intellectual. Look at each one, and you're going to decide how you're going to allocate your time, your energy, aka your cash. Find an activity that you like. Take your money, it's a sticker, peel it off, and pay for it. You will quickly realize that you, just like a sickle cell warrior, do not have enough currency to even get through the most basic tasks. So you're gonna need more cash. Now, all of our activities, our stations, from food and beverage, is going to get you currency back. Our sanctuary, get a massage, get a B12 shot. That is going to get you currency. This is how you, as a sickle cell warrior, will refuel yourselves. Camp New Light in the corner. We have many golf courses. Take a break, take a swing. You'll get cash. Play a game, you'll get cash. I'm going to give everybody some cash now because you've all had food and beverage, right? So once you get cash, use what you have. Go to the back side of this black panel wall at your leisure and start spending.
I ain't know we was reading this. I'm just giving out random money. Oh, that you can get.
Yeah. So it's teaching you about energy.
So we're giving away money, but the money that we have, that's enough to give away, or ask a question. That two separate things for the money?
No. They should be. You should be.
Right. Well, how much? We just
You need to see.
So it has nothing to do with this.
Yes. Well, the extra money they need to
Okay. Yes, ma'am. Is it two different ways?
So we have money, and they're giving us money. No. Nobody gives, everybody spends their money on food. Okay, so everybody starts. We are replenishing as they come in to our table. Yes, ma'am. But separate from this, like is there a certain dollar amount to give them or how much? Got it, okay. No, that's service. Okay. Service. Got it, okay. This is your spend. Okay. This is your spend. Okay.
I'm at the energy station, the light
All these are just different categories. And then, are they talking you're literally okay. They
I take out love. And I'm like, I know that I for me. And that's what pumpkin
So the key to this is all that so you can get all of the things.
But there are things that a lot of senior patients that could be daily needs are not getting access
I never knew about that.
Yeah.
They say that.
Great, that's the law. What are you actually doing? You know?
I think so. About medication for the week.
Okay. What else you about?
Am I gonna go to brunch or not? I don't know if I'm gonna brunch.
Y'all get your passport still? No.
Hold on.
Somebody I'm gonna let you get my nice though. So what type did you have?
Estimated there.
Okay. And I'm pretty sure you know where that is. Yeah.
I'm gonna attend the class.
Which one was yours?
I have trade.
Okay. You got your passport? I'm up here running my mouth and I ain't still heard. You stamped her? Yes, you did.
My money is running out fast. There we go. I think I'm good. Paid bills, went to the doctor, got my medication, went to a class. Wait, actually, I should probably exercise. Last thing I'm gonna do is exercise. Get back to we got a little bit of money left.
All right. I hope everybody has had the chance and the opportunity to go to all of the stations, visit the energy lab, and see how you're going to spend your genotype energy. I hope you had an opportunity to network, ask some questions, and have some very thought-provoking discussions. So moving right along, the next presenter I want to speak a little bit about. When it comes to sickle cell disease and nonprofit funding in general, government agency foundations and academic institutions offer data and measurement-centered funding opportunities. These grants and programs support the collection, analysis, and the application of data to help improve patient outcomes, understand long-term trends, and address health disparities in the sickle cell community. With us to talk more about this is Dr. Andy Snyder. Dr. Snyder's work focuses on applied research, policy and program evaluation, and technical assistance and program implication for state and community level health projects. Her research uses both qualitative and quantitative data, including qualitative, thank you, and quantitative data, including administrative databases to study the health outcomes that result from the organization and financing of public health systems. She also serves as a director of the Georgia Health Policy Center at the Andrew Young School of Policy Studies. And she has a joint facility appointment with the Georgia State School of Public Health. Her current research focuses on evaluating policy options for increasing health insurance coverage for children and the quality of care received by children enrolled in Peach Care for Kids, which is part of Georgia's Children's Health Insurance Program. Please help me in welcoming Dr. Snyder. Thank you so much for joining us.
Thank you. I was being like a nerd and I'm going to slides away. And I was also set up very nicely by the earlier panel this morning. So I might need to. Okay. Is that better? All right, let's see if I can do this. So I'm going to talk to you guys today mostly about the sickle cell data collection program, which we sort of talked about a little earlier this morning. I want you to think about this as a resource for everyone here in Georgia, but also because we've been doing this so long, our data is also really helpful at the national level to help you guys advocate for policy change. So I'm going to talk a little bit about the team of people that you might have worked with, that I work with at the Georgia Health Policy Center at Georgia State. Why there's a need to collect data in the United States on sickle cell, the history of how we've done this work, what data we have and how is it collected and from where, and then talk about how the data has been used. And then I'll answer any questions you guys have. So this is the team. Some of you guys may have worked with some of these other folks. It's me, Brandon, Nay, Lori, Sankita, and Zahan right now. I don't know how many of you guys know these folks, but these are all my colleagues. And why is there a need for sickle cell surveillance? Well, you all know that sickle cell disease is a newborn screening condition that babies get checked for, but it's only been in place for like 20 some odd years in Georgia. And it's not sufficient because there's people that move here from other places. They're not all born in the state. And people immigrate all the time. And people move around. And
Why is it important for us to know how many people are living here in Georgia with sickle cell disease? It helps to plan for disease management. It helps to do translational and health services research. It helps identify who's in need of new therapies. It also helps with education and targeted education. So this is a little bit about the history, and like I said, we've been doing this work in Georgia for now 15 years. And it started in 2010, and we were always in partnership with the Sickle Cell Foundation of Georgia, as well as the Department of Public Health. And we have been collecting data, we have data collected all the way back to 2004 in Georgia. And it's gone through several iterations. It started out as the RUSH project, then it moved to the FRESH project, and then it became the Sickle Cell Data Collection Program. And now, I think I said this before, there's 16 states that are doing this with us, and California and Georgia are the ones that have been around since the beginning. So we kind of help the other states along. We want to make sure with this data that we are accurately identifying and tracking the long-term trajectory of everyone with sickle cell disease in Georgia, and then we would like to have data at the national level. We collect the data from multiple data sources. I'll talk a little bit more about where those, what those data sources are, but these are the 16 states that are currently funded to collect sickle cell data. So while we're collecting individual level information from all these data sources, we're collecting it because we're probably going to find the same person in many of these. So we collect the data at the person level so that we can link it, and we're not double counting people, and that we have a better sense for all the different systems that might have information about them. But once we do link, so we link data from newborn screening, from the hospital discharge data, from Medicaid data, from emergency department data, from vital records, so birth and death information, and from clinical information from the sickle cell treatment centers. We then link it, and then we de-identify it and aggregate it. So we're looking not at individuals with sickle cell disease, but the whole population of people living with sickle cell disease in Georgia. And we have to have lots of partnerships with lots of you all and with all the centers that create all this data, and we have to make sure that we're doing it in a safe manner and protecting people's privacy. So what do we have? We have the total number of people living with sickle cell disease in Georgia over time. We know the number of kids born with sickle cell disease in Georgia each year. We've got the demographic information about them, their age, their sex, what zip code they live in, what county, what their diagnosis is, and genotypes for many of them. We know their healthcare utilization patterns. How often do they go to the emergency room? How often do they have an inpatient stay? And what prescriptions are they filling? And we have who's paying for that, if they have Medicaid or Medicare, or they're paying out of pocket. So yes, the goal of the SCDC program is to inform policy and practice improvements that extend the quality of life, life expectancy, and health of individuals with sickle cell disease. What data, a little bit more about what data we don't have. We don't have like employment records on folks. We don't have private sector information. We don't have any patient-reported data. So we don't have surveys of patients with sickle cell disease. We don't know anything from them. And we don't have any other government data other than health data currently. We would love to get additional data, but right now we don't. And let me tell you a little bit
a difference between clinical data that you might find in someone's medical chart and administrative data, which is mostly what we have. So the clinical data is, think of it as individual level, like your medical record. It has information about your height, your weight, your vital signs, your physical exam results, your laboratory test results, things that you've told the doctor about your history, the medications that were prescribed to you from your doctor, and your plans of care and your follow-up visit when it's scheduled for. What do we get in the administrative data? First of all, it's population-based. We're not looking at individuals. We're looking at patterns of their healthcare use over time in the populations. We're looking at how many hospitalizations they've had and their emergency department visits. We can look at other things that they've been diagnosed with. We can look at the prescriptions that were filled and picked up at the pharmacy rather than the ones that were prescribed. We can also see if a follow-up visit was kept, but we don't know if it was scheduled or if it was changed. And we can also see the tests and procedures that were performed, not the results of those tests. So this is just a little bit about some of the data we have and how many folks we have from each of the data sources that we have. I will say, so we've been collecting this data for a very long time. We're one of the longest standing data collection programs in Georgia. And since 2004, we have identified 16,000 individuals that have lived in Georgia or gotten care in Georgia up until today. But if you look at it on a annual basis, there's probably around 9,000 to 10,000 people on any given year with sickle cell disease that we get from our data sources. So you can see that we have also a pretty large number, almost 2/3 of them that we collect on an annual basis, that we know their genotypes because they've been either reported from a clinical source or newborn screening, and they've been matched with some of our administrative data. Here's some other uses of the data that we've had, other than just identifying people and counting them and kind of their demographics. We also have a lot of geographic information. So we have used some of the geographic information about where people live and where they receive healthcare to create some of these types of maps so that folks can see where they can target interventions and where they might need to send community health workers out, for instance, or do some provider training. So this map over here is an example of the blue colors are where, how many births with sickle cell have happened in that county over, I think this is maybe like a 5 to 10 year period. And then it's mapped with an overlay with the stars are where there's treatment centers every day, and then the smaller dots are where there's periodic clinics, so there's like outreach clinics that maybe on a monthly basis are serviced, and then you can see the slash marks are basically the 1 hour distance from these sites. You can see there's a lot of areas in Georgia where there are people living with sickle cell disease that have more than an hour to go, even to and these are little kids that have more than an hour to go just to get to an outreach clinic. So there are a lot of access barriers for individuals in Georgia living with sickle cell disease. We've also, and we've definitely worked with the foundation to identify the areas. I know that they have a whole community health worker program, and we've used this to sort of map where they could use community health workers. I know that folks have used this to establish mobile and virtual clinics, and also sickle cell support groups and blood drives. The other thing that we've done is looked at sort of preventative care for children, especially, to drive sort of quality improvements. So you all know that individuals living with sickle cell disease have to do a lot of preventative maintenance in addition to taking care of themselves and making sure they're hydrated and eating correctly. And there's some things that they need to do, like vaccines, extra vaccines that they need. They need to take antibiotics. And so we've looked at how many folks living with sickle cell disease are meeting those preventative care guidelines. And we have recently put this together in a brief that folks could use to show that while we're doing some things, we're not doing optimally. Not everybody in Georgia with sickle cell is getting all their preventative care. So if this could be helpful to you as you're sort of advocating for additional policies to improve access, we can provide that data for you. Oh, I did want to mention, and I don't know if Dr. G is still here, but one of the things that we are using this data for is to sort of advocate for more long-term follow-up for individuals with sickle cell disease. So we do have a newborn screening program, but mostly once the children are born and then get connected to care at one of the centers, there really is no tracking of them over time except for what is happening at the clinical centers. So if they get lost to follow-up, there may not be anybody that knows about those. And then they show up a few years later and they're in real trouble. So one of the things that we're trying to do is use this data to get more of in the EHRs at some of the follow-up centers. There is a way to create an epic sort of dashboard for the doctors. So if there's a child in there getting following up for one of their care visits, it'll show them right away, oh, this child is in need of their a penicillin prescription, or this child needs they need a vaccine. So that can kind of happen, and it can give data to the clinician at the point of care. So we're trying to work on getting those, and I know Dr. G is working at Children's with some foundation money to build that dashboard. The other thing that we're doing this current year with our sickle cell disease data collection money is working with the warriors to kind of create a photo blog about what is it really like when you get, as a parent, when you get the information that your child has sickle cell disease. How does that work? And what's the information that you want at what time? And how can you connect them to folks that can help them receive timely care and help them with whatever the family needs in support of taking care of children with sickle cell disease. So one of the things that we're doing right now is working with Montpelier, and she is going to be asking for folks that she can interview so we can create a blog for parents so that they some parents can tell their stories of getting their child diagnosed and how that worked. And that maybe will help other folks in the future. So these are some of the ways that the data has been used to sort of change things in Georgia. One of the things that happened, they used some of our data to show that there was really a lack of services in Columbus, Georgia. And they were able, with a lot of advocacy from a lot of folks in this room, get a sickle cell clinic in Columbus, Tree of Life Healthcare. So they used some of our sickle cell data collection data to show that there was a need. The other thing I know that the Sickle Cell Foundation has used our data for is to plan for where they're doing their healthcare provider education trainings, and also to, like I said, deploy their community health workers. And these are just some examples from other states that are part of the sickle cell data collection program and how they've used their data to advocate for different policies and changes in their state. So I know California also used some of their data to get a new clinic in Los Angeles County. And lots of other folks have used it to boost their sort of advocacy efforts in their states. I want to end on a note of if there's any data that y'all need, if you need us to supply data for your advocacy efforts or your policy engagement activities, please let us know. And there's an email and there's also a website that we have where you can put in your data requests. All right, I think that's it. Go ahead, Tabitha.
So, this showed us that
Yes.
how do they differ by the way when you're reporting them? Do you use data or do you use administrative data?
We mostly have administrative data in our SEDC program. So we're almost always reporting the administrative side. We are in conversations with some of the sickle cell treatment centers where we might get more access to their EHR data, but right now we don't, in Georgia, we don't have any electronic health record data in our SEDC program.
So that's the goal of it.
Yes, I mean, one of the goals of the grant is to keep increasing, adding data to the sickle cell data collection program. So yes, we're talking about doing that. And you can see there's subtleties in how it is, but yeah, it's mostly, the administrative data is mostly, it's actually collected at the site of where you're paying for things. So you can tell, you know when people are like exchanging money or whatever, that's what it's really collected for. It's not collected for patient care purposes or like the clinical data is, but mostly it's easier to get access to because it's already out there, right? All that, all that insurance information about every time you pick up a prescription, you have to have your insurance card. So that data is already sort of collected. And so it's easier to grab it and use it to sort of look at where's everybody accessing services, where are they filling prescriptions, what are those prescriptions for, that kind of thing. Okay.
How confident are you in the 16,000 number that's living here in the state of Georgia with sickle cell disease?
So that number is,
I have two parts to that.
Yeah.
So how confident are you with the 16,000 number of individuals with sickle cell disease in the state of Georgia? And yeah, how confident are you? Then I'll come back.
So that number, the 16,000, is since 2004. So it's basically, since we started doing this, we've identified 16,000 individuals. However, probably not all of them are currently here in Georgia now. Some have passed, some have moved, some have, so I would say if you were saying right now in Georgia, it's probably closer to like 12,000 people, maybe a little bit more, it's around there. Because we can look at over a year, we know that we can see, we just had a year's worth of data, we can see over 9,000 people. But a lot of people are not living with sickle cell, might not access this health system in that year. So there's probably a few thousand more that are living here that haven't accessed the healthcare system. But that 16,000 is probably too large for like, right now, right here, there's that many people. I think that's a little bit too big. So it's probably around 12,000 or something like that. If we would say today, there's that many people living here. And there's also people who live all over the borders, and you guys have talked, they go to Florida, or people from Florida come here, so it's not like a border is preventing people from accessing services. And I'm sure people in the Florida program, we share a few people with them, people that live on the border, so.
Well, I just want to say thank you for the great work that you do. I'm really happy to be a part of you guys.
Thank you.
Hi, good morning. I've got two questions. I've got a lot of questions, but the two of them recently in Georgia, we passed all the legislation that established that all payers claim benefits, ABCD, as it's called. And this takes inventory. It is not proprietary information that sits there, as you know, about what the actual costs are to deliver. I noted on one of your slides that one of the data points you said don't necessarily have access to is that private, commercial paid data. So, part one of my question there is there, do you regard the ABCD as an opportunity to maybe build that blind spot? And if so, is there something we can do to accelerate that? Because one of the points that we talk a lot about capital, particularly with regard to appropriations, that was also on the slide, is the cost to deliver care in somebody's home community, primary care, doctor and hematologist is entirely different than the cost of somebody going to the ER. We are about to see ER visits for sickle cell because of the National Climate of Healthcare. ERs are about to be funded across the board. Sickle cell patients are going to be a part of that. So my first question is, how can we better integrate, or do you have plans on integrating ABCD type of data into yours? And my second question is, given that our legislative session is around the corner, and a lot of the data that we reference here today is central to our argument of cost savings, which in a budget environment is going to be that much more. So how immediately accessible is this data to us that you've already collected? I know you said we could go out of form and some. The new data from the ABCD and the existing data and our access to that are
So, yes, I'm actually on the data governance board for the ABCD, and it is exactly the same data that we have. We just have only Medicaid claims, and they have all the, well, I don't know all, but they have a good chunk of the private claims in Georgia, depending upon whether the insurance companies are participating, because it's optional. It is great data. The problem is that data has its own they make it so you can't request identified data from it. So the problem we would have would be, we wouldn't be able to link it to our other data to make sure that we're not double and triple counting. And I'm not sure we're actually allowed to even try to do that legally with the data sharing agreements we have. However, that wouldn't preclude us from just using that data to do more of a general look and to see, what is going on with people that have private health insurance with sickle cell disease. We'd have to use a administrative definition for sickle cell disease. We wouldn't be able to say for sure that this person is the person over here and they have sickle cell, their SS or whatever, because we wouldn't be able to link it to our other data. So, but we could do that, and we were looking for a use case. That data is quite expensive. So right now, it would be probably $20,000 or $25,000 for us to include that data. But we're trying to work with our partners in public health to see, do they get a discount? I didn't really mention this, but we are doing all this under their sort of guidance because they have public health authority to waive I'll throw out a HIPAA word, but that basically allows us to collect this data without telling people that we're collecting the data, because we're not looking at individual level information. So anyway, we have, that is on our agenda, and we have an interest in getting that data. It's going to be difficult to get it, though, where we can link it with all of our other data. We probably have to do that analysis separately. And then you had a second question.
Just about how we can, with legislative session being around the corner, and some of the data decided being very, very, as they start appropriations work less, how do we best quickly access what we do already have?
If you want to talk to me, or if you'd rather call rather than fill out a form, or you can fill out a form and then say, can I follow up and tell you exactly? Yeah, just let us know what you need. We probably have something close that we can give you right away, and then if you needed us to update the numbers, we could probably do that too. And we have done some very small things, like if you're working directly with a very particular legislator, that has an interest in sickle cell, we could just pull the data from their kind of, their district or whatever. We've done that before. When ASH was trying to get some of the national legislation passed, there was a few people that they were targeting in Georgia, and we just pulled the data for them, and then we did a briefing with just them and talked to them about their constituents and who was living with sickle cell. So all that is possible.
I will pre-put a time request for the Savannah area data.
Okay.
So central.
Yeah.
Yeah. If you had a wish list of data elements to add on to, what would you request? What do you feel like you need, and how would you prioritize that?
That's a really good question. I would love to have the all-payer claims data because that would round out, because a lot of what we've done is with the Medicaid claims, and that's probably about 2/3 of people, and we know how difficult it is for adults to, they actually have to be disabled before they can get on Medicaid in Georgia, except for the two pathways, which is, our expansion, which is pretty small. That would definitely be data. We have linked it with some, if public health has access to it, they will allow us to link. So we've linked with our immunization registry. That's how we've gotten the immunization coverage rates. We had a program, we had a small internal grant 2 years ago, and we were able to link to the prescription data monitoring to look at opioid prescribing and where warriors might be getting their, or not getting access to opioids because of the opioid epidemic, which is kind of on top of everything, and it makes it very difficult for people to get opioid prescriptions, even for people that need them for pain. Let's see. There's a lot of great, like I said, we're working on the EHR data, and I was talking to Dr. G. We also have, you guys, I don't know if you know this, but we have an investment from the state of Georgia, from the governor, for the Solve Sickle Cell initiative that folks at Emory are leading, and it would be great if we could integrate some of that data too. It sounds easy, but it's really hard. It's really hard to link all this data because there are so many privacy controls around people's health information, which we don't want to violate. But when I say that, it would make it great for researchers, and it would be great for me to be able to answer any questions you guys have with data. It's like, well, how many, whatever, and how many people are reporting that they had this, and we just don't have some of that information. I think that enough. I would love any data that I can get my hands on, but some of it is like, I know it's probably a 10-year process, and I'm like, it's just not worth it. The bang for the buck is not worth the 10-year process to try to get it. But the other thing that we talked about this week when we had our sickle cell data collection advisory meeting was education data, because one of the things that our grant had asked us to do is kind of get into another area that's not health and try to collect some data from that and make some policy. So folks were really energized around the intersection of education and health. And so there's 2 states I know in the program that do have some of their education data linked with their health data. So that would also be really very, very, I know it's, I think it's Missouri and Tennessee. Yeah, I think they linked. It took them a few years, but I think they're almost there. So they're able to look at like 504 plans and IEPs and that kind of thing, and look at the trajectory of the kids' academic outcomes.
I think there's a great opportunity for the community health worker group with some of this data. We prescribe a lot of antibiotics, but only 15% of Medicaid recipients are picking them up and taking them. So I think that that's a really important area of interfacing with the patients and families, is to encourage them to take their preventive medications that are prescribed.
Yeah. Yes. Okay.
you, Dr. Snyder. Thank you for all of that great information about the metrics and the data that you collect. So right now, we are about to take another wellness break. I think we need another wellness break just so we can go ahead and network and talk amongst ourselves and hit up some of these stations that we work so diligently for you guys to see. So we're gonna take a quick break and then we'll be right back.
The Sickle Cell Legislative Conference and Policy Review will return in 15 minutes. Please use your passports and visit the different stations.
Good afternoon, everybody. I just want to let you know that as we're taking a little bit of a wellness break, we do have a couple of things to offer you. If you visit the wellness station, you will see that we are raffling off a free service valued at $120 at the wellness station. You can get your QR codes ready so that way you can get that raffle. We also have Sickle Cell Foundation of Georgia sweatshirts that are available for sale. So please make sure that you are supporting the Sickle Cell Foundation of Georgia and take advantage of the things that we're offering to you. Thank you.
Curious of what's important to you.
Well, no, I paid all and then I went to church, and then I went to physical wellness.
So, all right, you made it good today, hey, man.
And then, so then I'm coming back.
Oh, you got money.
So you don't have a file?
I got some more, but no, what I was gonna do is.
How we gonna get you
No, because I'm gonna have to.
Okay.
Right, so then I'm gonna put 23 down, and then we'll get the 10. The other two coming I spent a lot of money on it. I need some change. On the church, I'm gonna pay my bill. I wear the song. Now I'm gonna go back. I am gonna work, and then I'm gonna go. I'm gonna make my meal prep song. Meal prep should be up on I did this over here for family. But I really I've been walking on. You already did. I did my physical wellness. Yeah, take it. All of my bills, my daily living expenses, I said they're for the family. So for my physical, if I'm going to church, I'm already probably doing it. If I'm going to church, I'm taking to the
All right, and we're getting right back into it. So may everybody please take your seats for our next presenter. Going right back into it, ladies and gentlemen. Everybody, please grab your seats so we can get ready for our next presenter. Thank you. Georgia State House Representative Omari Crawford was first elected in District 84 in 2022, and he has not wasted any time. Representative Crawford is a former Assistant District Attorney for DeKalb County. He is a member of the Insurance, Intergovernmental Coordination, and the Judiciary Committees. He has introduced two pieces of legislation, House Bills 334 and 336, that will help improve sickle cell disease care and increase awareness of sickle cell disease. The bills were introduced this year before the end of 2025 legislative session and aim to help Medicaid recipients and school-age children with sickle cell disease. He is here to discuss these measures and what they do and why they are so important. Please help me in welcoming Representative Omari Crawford.
Morning, everyone. As you heard, I'm Omari Crawford. I'm the state rep of what is now Georgia's 89th House District that includes South DeKalb County, the city of Decatur, and it moves up towards areas of the city of Atlanta to include Emory University. I grew up in South DeKalb County, so I have the pleasure of representing the area that I grew up in, which is a unique challenge in itself, and I enjoy it. I was elected in 2022. I made it in the state house for years, and as you heard, I served on judiciary, I served on intergovernmental relations and insurance. I'm an attorney by trade, but I've been a sickle cell advocate my entire life. Let me explain. Growing up in South DeKalb County, some of you may understand that sickle cell is prevalent in DeKalb County and Fulton County, particularly Decatur, where I grew up in. I had many close friends who were impacted by sickle cell, and I had to be taught at a very early age what it is and how it impacts my friends. So I became an advocate very early. I had the pleasure, after graduating from law school, to join My Three Sicklers, a sickle cell nonprofit organization founded by my friend Don to become a stronger advocate, understand how I can best serve. So when I got introduced into the General Assembly, I sworn in, I learned that there was a sickle cell day at the Capitol. I was unaware of that previously. And so I saw so many sickle cell advocates and warriors coming down to the Capitol to advocate for people impacted by sickle cell. And so I realized that there was an opportunity for me to draft legislation that could help people who are impacted by sickle cell. And I want to give a shout out and a very special thanks to my friend Tabitha, who led the charge, Tabitha, who would come to the Capitol. And what I realized is that in order for us to combat this, we have to be one. We have to be a youth. We have to be as visible as possible, as knowledgeable as possible, because in my 3 years, what I've learned about politics is your intelligence may or may not always be important. But what's most important is numbers. You can pass legislation in our state house or even at the federal level if you have the numbers. So before I get into this bill, what I want to ask you to do is learn who your state rep, who your state senator is, call them, email them, come to the Capitol when we start our legislative session in January and tell them that they need to pass measures that will better protect people who are impacted by sickle cell. There are strengthening numbers. Number two, once we figure out when the sickle cell day at the Capitol will be for the session of 2026, I need everybody in this room, and everybody that you know, try to find your way down to the Capitol. Let me tell you, even if I don't know what a bill is or what a bill is doing, if I come outside of that House floor and I see thousands of people supporting the cause, I'm gonna read it. I will be dumb not to. So the more people who are there at the Capitol advocating for sickle cell, the more likely we are to pass legislation that will protect people that are impacted by sickle cell. So those are my two challenges for you. Okay, politics can be scary, no pun intended, because it's Halloween. But the way that you combat some of those challenges is you show up in numbers. Now let me get to the two bills and what they would do. This past session, I introduced a bill 334. I originally introduced it during my first session, but it did not pass, it didn't receive a hearing, and I'm confident that it may receive one down. 334, which was originally called the Bill of Dunn Act, we have now changed that title to just the Sickle Cell Protection Act. It is a bill that will require Medicaid to conduct an annual study review of the medications and treatments that we use in sickle cell patients and individuals living with sickle cell disease. And the purpose is to determine if the available covered medications and treatments are positively helping people impacted by sickle cell. So we have done annual reviews for other medications. We're simply trying to do an annual review for sickle cell medications to see how we can better treat, how we can better take care of people impacted by sickle cell. I'm sorry, I saw somebody behind me that's steering for a second, okay? 336 is another bill. 336 does, it would require educational systems throughout the state, if they are already sharing information about other diseases on their websites, to include information about screening, about the importance of getting your medication and treatment as pertains to sickle cell on their website. This is a preventative measure, but it's also a proactive measure that will ensure that we can empower our families that are impacted by sickle cell, that we can promote health equity, and more importantly, we can increase awareness. I told you that I was a sickle cell advocate at a very young age. When I was young, I had a friend who participated in sports with me. My background, I'm an sports fanatic. A friend of mine who participated in sports with me had a sickle cell episode when we were competing at one of our local schools. The teachers were unaware that he had sickle cell. At the time, he was unaware that he had sickle cell. It was an episode, he is fine, he has continued to live a healthy life, he will continue to live a healthy life. But if we can empower teachers, faculty, and staffers, and families, knowing the importance of being trained, knowing or making sure that our faculty and staff members know who has sickle cell, be able to better protect our students. This bill came about because a colleague of mine, and sometimes you just have to pay attention to the state house, a colleague of mine, who I respect very much, passed the same measure for diabetes. And I thought to myself, this is a wonderful bill to protect students who have diabetes. But this works for diabetes, why can't we do the same thing for sickle cell, something that's very prevalent in my community? She blessed it, other people blessed it, and now it's time for us to try to get this measure passed. And I'm very confident that we are going to have a hearing, as I am looking outside and seeing one of my other colleagues coming in now. So we want to urge him when he comes up, okay? Don't tell him that I told you, but let's urge him to make sure that we pass House Bill 336 and House Bill 334. Again, I really appreciate the opportunity to learn more about sickle cell, and I'm very honored that I can be an advocate and to try to pass legislation for people who really need our help and need our protection. I'm also blessed that the redistricting for 2024 placed Emory University inside the district that I represent now. And so now I've been talking to doctors at Emory as well as doctors at Morehouse School of Medicine and Grady to figure out how we can collectively get these bills passed. And again, as I said to you, unity is important. Numbers, that is the most important factor when it comes to legislation. So I appreciate you coming here today to learn more about the bill and how you can be better advocates. And if you have any questions, I will stay and take questions. If not, I appreciate the time. I heard you.
Okay, Group 6, right? Education awareness.
Yes.
What does that look like? Because I know that can change the way people, young adults, live and sit themselves in schools with their peers actually knowing what they go through. So what is that education, if you had to envision it look like?
I appreciate it. I think it does a few things. One, it increases the awareness of sickle cell within schools. I think it adds a layer of protection. I think it empowers families and students. Sickle cell and other things that people local cannot be seen as something that is a taboo thing. It can't be seen as something that we should stay away from or something infectious. It is something that we need to better understand, something that we need to better accept, advocate for, and better protect. My vision is to make sure that this bill passes so that parents, faculty, staff members, and teachers who may not have sickle cell, may not be impacted by it, all the protection students do that. I think the next thing is making sure that if we know the students that have sickle cell disease, to offer better protection to them. When we're talking about extracurricular activities, and then engaging in whether it be athletics, band, whatever it is, just so we can ensure that they are healthy.
Thank you.
Thank you. I'm sorry, we have a question.
Thank you. You mentioned that 334 didn't, I think it was a year and a couple years ago you passed it or brought it up. I was wondering what was the opposition or the reason why during that time it wasn't ready to receive?
I appreciate that question, and I apologize if I misrepresented. It did not receive a hearing. We talked to the chairman at the time, very briefly. The legislative process, our session works like this. We're in session for 40 days. Very intense 40 days. We pass bills that are impacting everybody in this state. And it's, again, squeezed into a 40-day period. That 40 days bifurcated into two parts. The first part, if you get your bill heard in that 20-day period, then you meet what's called the crossover deadline. That means a bill that originates in one chamber to cross over to the other chamber. I hope that I'm not confusing anybody, but that's a lot, right? We didn't get a hearing. There was no opposition when we spoke to the chairman of the committee, but there were other priorities that beat us. So we had to pass it again. The bill is essentially allowed for a 2-year period. We didn't receive a hearing within that first 2 years. We now believe we will receive a hearing now, this upcoming session. Part of that is the governor in June of this year passed a proclamation and resolution from his office emphasizing the importance of advocating for sickle cell. So we know that this is one of the governor's priorities, and we're hoping in his last year in office and others that have seen the importance of advocating for sickle cell, that we can get a hearing. We've got one bill, hopefully both bills, but if not both, one at least.
I know that Day at the Capitol is one of the opportunities for us to have a collective effort, like you said, moving forward in numbers does appeal to the eyes. Is there another collective effort opportunity that exists?
I'm sorry, yes, I'm listening. The opportunity that exists, absolutely. The first bill is going to be in the Public Health Committee, 334. The next bill is in Education Committee, 336. Another way that you collectively advocate for each bill is to figure out who the chairperson is. Presently, that chairperson is Representative Lee Hawkins for the Health Committee and Chairman Chris Irwin for the Education Committee. Their information can be found on the public website, the Georgia General Assembly website. Emailing them about the importance of this bill having, each bill having a hearing. I think if you do that in numbers, that's an opportunity for the bill to be heard. And I think these bills are very good measures. I don't think the question that was asked previously, would there be any opposition? I don't think that there's any opposition. These are bills that, if passed, they look almost like other bills for different diseases. So those bills that pass, then you can assume that the bills that we have are going to pass. 334 is Irwin, Chris Irwin, Representative Irwin, Lee Hawkins, and Chris Irwin. Oh, very well, thank you. So I don't see any opposition. That again, numbers matter. When you're talking to your colleagues on both sides of the aisle, you're talking to people who work for organizations that may have interest in the bill. You ask them whether or not they would be opposed. We have found no opposition. Again, I think the safety net is we've seen other bills that look like this also pass for other matters, right? So again, if those bills pass and provide the powers to pass, the sickle cell impacts 10,000 people in our state.
What's the best time to send these kind of emails?
That's a wonderful question. We start session in Georgia the second Monday of every January. That is what, January 13th? Yes, no, January 1st. We start session January 12th. My assumption is that the people who I just named still be the chairman of those committees. I don't make the decisions to determine who will change or if there will be a change. But I think January 12th is when you should probably start sending these emails. That'd be the best time because we'll be in session. Right now, everyone is back in their respective areas, districts, and there are so many things that are happening. We don't want to critique at the national level, so people may be more focused on some of the things happening in their districts than what bills may or may not be heard this upcoming session. So I think January 12th, when you start, will be the best time. And especially in those first 2 weeks, as we're trying to determine what bills can be heard before we reach that crossover date that I mentioned. Other questions? There are.
I don't have a question. As a community health worker, before January, like I would like to introduce, advocate more for my clients and peers for them to invite them out to the Capitol. So to talk more about this, can I get with you so we can maybe help you with that so that I can put it in my outreach packages so that I can try to get more parents and more of them out to the Capitol.
Absolutely, I would appreciate that. We don't know what our legislative schedule looks like just yet. We should know within the first 4 or 2 weeks that we start session. Tabitha has been incredible in making sure that she is down at the Capitol. That Capitol is completely rigged, okay? We're down there sickle cell day at the Capitol. So the minute that I know, I will make sure that I communicate that with everyone. And we want you down at the Capitol. I think that, again, ensuring your numbers, if you come down and understand who your state rep, state senator, who they are, you'll have a better opportunity to have that one-on-one conversation with them and be able to communicate why these measures are important. So, absolutely. It's tough for me to tell you in December, for instance, when we will have sickle cell day at the Capitol, but hopefully by the first 2 weeks of January, we can pinpoint the date. Thank you. Yes, ma'am.
I'm probably not enough. So for House Bill 336, do you guys have any kind of collaboration with any like teacher organizations or anyone that's in, the education field? kind of shown that there's strong support on both sides, both medical, CBO, and education?
Wonderful question. And I'm going to answer your question by saying yes, and then going to what I typically do. Anytime that I draft a bill down at the Capitol, what I like to do is reach out to the departments who could potentially be impacted. Figure out if they oppose it, if they support it, or, which is just as important, if they're neutral. Because sometimes they may not want to write a letter of support. They just say, you know what, we have a problem with it. It's equally important to ensure once, if you have a hearing, that there's not a department that's sitting there saying, we don't like this, so support this legal thing first. That measure 336, I spoke with the Department of Education and I spoke with the Department of Public Health, just to ensure that they are okay with the bill. They say that they have no problem with it. I am not representing that they would be at a hearing supporting it, but they have reviewed the legislation and they do not oppose it. But wonderful question, thank you. Right, if there are no more questions, I just want to thank you for allowing me just to come in and speak. Thank you for having me.
Thank you, everybody. So this will conclude the program, but please do not go anywhere. We will have our Gloria Frazier Award ceremony in just a few minutes where we honor some of our representatives who have done so much work in the sickle cell space, and we are more than encouraging you to come and be a part of this reception and have lunch with us so that way these representatives know the basis of those who support them as well. So, pop quiz. I have a couple of questions for you, and I hope you can answer them for me. What is the one thing Representative Crawford said would help get bills like 334 and 336 passed on the Senate floor? Yes, show up in numbers. So make sure that if you are not following us on our socials, that you are following the Sickle Cell Foundation of Georgia on all platforms so that you are aware when it is time for Advocacy Day at the Capitol, so that you will be with us in our red, making sure that the bills for our warriors are passed. Next question. I promise you it's not a lot. Okay. What are the two bills that Representative Crawford are sponsoring? 336. That's right. I just don't want you guys to forget that. It's so important for our warriors. So make sure that you keep those things in mind. And when should we go and represent for sickle cell at the Capitol? In February, when there is Sickle Cell Advocacy Day at the Capitol. You guys, that was so easy, right? So, moving forward, I just want to say that we are about to flip the room. So this does turn into a reception for our representatives. You are able to go to the edges of the room where we have our activations. If you have not fully participated in these activations, I highly encourage you to. It is meant to be engaging, it is meant to extend the conversation, and it's meant to put yourself in the shoes of a warrior if you don't already know what it's like. We also want to mention that there is a raffle. We have a raffle going on for our sickle cell sanctuary. It is valued at $120, and it is for any service at our sanctuary. You will be able to scan the QR code at the wellness station for a chance to enter. We are also selling our sweatshirts at registration. So please, it's getting cold out. Go ahead and support us in a red or black sweatshirt for the foundation. We'll have two of our employees out there to handle that. And as well, I don't know if you know this or not, but Did you know we had a talk show? Yes, y'all not giving that enough love. Did you know we had a talk show? Yes, this is a full production talk show. It is called Unveiling Sickle Cell Beyond the Pain. And of course, our beautiful CEO is the host of this show. And guess what? Season 1 is out right now on YouTube. Right now, at unveilingsicklecell.com. So we have a website, we have merch on the website. Please go out and support us. Everything we do at the Sickle Cell Foundation of Georgia goes back and directly helps our warriors. We have so many programs and services that everything that we do is all in good-hearted effort to go back into the community. So please, if you can, do the most and visit the stations. Watch us on YouTube, get a sweatshirt, and stick around as we honor 4 state representatives. Thank you.
Hi, I'm Ava, your advocacy virtual assistant. It's time for a word from our sponsors. Thank you. Pfizer. Agios. Beam Therapeutics. T-Remote Blood and Cell Technologies. Find Federal Dispensary, located in Smyrna and Decatur. Scan the QR code to enter for a chance to win a free service at the Sickle Cell Sanctuary. Scan the QR code to attend the 4th Annual Black Tie Gala, Diamonds and Tuxedos, Saturday, December 13th. Scan to donate to the Sickle Cell Foundation of Georgia that directly helps the warriors we serve. Hi, I'm Ava.
We're about to, we have some black law. Yeah, I guess.
We in the middle of deciding on the Beyonce concert. Jesus. Beyonce. See? No. You heard Jesus say you said Beyonce. You decided on Jesus. Talking about Beyonce.
Listen, I'm in the beehive. I'm not a fan.
We need change. We got to change. We need 5.